as the chief guest and deliver a talk. Thank you, sir. Now, not taking much time, I would now request Dean HPNI, Professor A.K. Tyagi, to deliver the welcome address.
Respected Dr. Sudhir Gupta, Director TMC and Chief Guest of today's function. Respected Dr. R. Chidambaram, former Chairman AEC, Secretary to DAE, and former PSA to Government of India. Honorable Vice Chancellor, my colleagues from HBNI Central Office, all the associate deans, faculty members, officers, those delegates who have joined online as well as offline, very good afternoon and welcome you all to National Technology Day 2024. To begin with, I would like to quote none other than Dr. R. Chidambaram, wherein he says, national security and national development are two sides of same coin. One cannot have national security without having national development, and vice versa also is equally true. I unquote. In this direction, Government of India took a major decision of going for Pokhran 2, which was popularly known as Operation Shakti on May 11, 1998. This day is a landmark day in the history of India, when India conducted 3 tests and 2 tests were conducted on 13th of May. These experiments demonstrated to the world technological prowess of our country. And we are very glad to have with us the architect of Operation Shakti, Dr. R. Chidambaram, sir. Sir, welcome you. This major event made India 6th nuclear state in the world. Soon after, then Prime Minister Sri Atal Bihari Vajpayee declared May 11 as National Technology Day. The first such celebration was held in the year 1999. Last year, we witnessed Silver Jubilee of National Technology Day, which was graced by Honorable Prime Minister of India. HPNI has rich traditions of celebrating all these days of national importance. National Technology Day is one such day. We invite distinguished persons for delivering a lecture on this occasion. This year, we have with us Dr. Sudhir Gupta, sir, Director TMC, who we all know is an internationally acclaimed oncologist. Today, he is going to talk on innovation and research at TMC, practical solutions for affordable cancer care in India, which amply reflects the theme of National Technology Day. So on my own behalf and on behalf of HBNI, I feel honored to welcome you and to express a deep sense of gratitude. You have spared your valuable time from your very busy schedule. Let me once again thank and welcome you to HBNI on this important occasion. Thank you very much.
Thank you very much, sir, for a very warm welcome. May I now request Honorable Vice Chancellor HBNI, Professor Mudali, to welcome our esteemed guest, Dr. Gupta, by presenting to him a bouquet of flowers.
Welcome.
Thank you, Professor Mudali and Dr. Gupta. May I now request Honorable Dean HBNI, Professor A.K. Tyagi, to welcome our Dr. R. Chidambaram with a floral bouquet. Thank you, Professor Tyagi, Dr. Chidambaram, and Dr. Mudali. Now I request Honorable Vice Chancellor, Professor Mudali, to deliver presidential remark and introduce our speaker for the day.
Distinguished Professor R. Chidambaram, the chief guest for the National Technology Day, Dr. Sudeep Gupta, my senior colleagues from HPNI, the participants for the National Technology Day 2024 of Homi Bhabha National Institute, students and scholars. I am very happy and delighted to welcome you all for this special lecture on the National Technology Day on innovation and research at TMC, practical solutions for affordable cancer care in India. I am doubly delighted that we have with us Dr. R. Chidambaram, the architect of both Pokhran 1 and Pokhran 2. Pokhran 1 was in 1974 and Pokhran 2 was in 1998, and who is the numero uno behind the Operation Shakti. And I'm delighted that he is now the director at Tata Memorial Center. And recently I attended one of his lectures during the Chintan Sivir at TAFR. And it was really amazing the way he put up how the technology is now today taking over in cancer care, particularly for our country, and what TMC is doing to this effect. So we felt that from HPNI, we should invite him as our chief guest for the National Technology Day. Thanks that you are really agreeing to our request and joining today for delivering the lecture. And for the benefit of all those who have assembled here, I would like to read a brief introduction about Professor Sudeep Gupta. Dr. Sudeep Gupta is currently Professor of Medical Oncology and Director at Tata Memorial Center at Mumbai. He completed his MBBS, MD and DM, all from the prestigious All India Institute of Medical Sciences, AIIMS, New Delhi, in the year 2000, and he joined a faculty in the Department of Medical Oncology at Tata Memorial Center at 2000. Dr. Gupta also served as the director of the Advanced Center for Treatment, Research and Education in Cancer at Navi Mumbai from December 2018 to November 2023. He is an internationally renowned breast and gynecological cancers oncologist and a prolific clinical researcher who is actively involved in planning, organizing, conducting, and analyzing phase 1, phase 2, phase 3, and phase 4 clinical trials. He has been a principal investigator, co-principal investigator, and co-investigator in more than 500 clinical trials with special interest in breast and gynecological cancers and clinical genomics. He has published more than 380 papers in peer-reviewed journals. In his current position as Director TMC, Dr. Gupta is engaged in facilitating crosstalk between various stakeholders in cancer research at the institutional as well as national level, including basic scientists, clinical researchers, computational biologists, physicists, engineers, and others. His main research themes are implementation science, including access to medications, guideline development, testing concepts and technology in clinical trials, innovative therapeutic strategies, toxicity and quality of life studies, pharmacokinetics, and translational studies involving next generation sequencing technology. He is a member of several national and international committees and task forces of Government of India, including DBT, DST, DAE, ICMR, Niti Aayog, ESMO, and others. We are really very proud that Dr. Sudeep Gupta accepted our invitation to deliver us about the innovation and research at TMC, practical solutions for affordable cancer care in India. A warm welcome to you, sir, and looking forward to your lecture.
Thank you very much, sir, for the introductory remarks. Now it's time for all of us to hear to Dr. Gupta. So we are eagerly awaiting for your warm talk. So over to you, please.
So can I control the slides from somewhere or shall I have to? Let me see. नहीं आ रहा. Is it? No. Yeah. Now I've done it. Yes. Thank you. Very good afternoon to everyone assembled here. I think it is one of the high points of my career to deliver a talk such as this in the presence of Dr. Chidambaram. I used to read about him, as everybody has said, the word technology day, and the word technology is actually synonymous with somebody like Dr. Chidambaram. And India is what it is today in terms of some technologies because of leaders and visionaries like him. So, sir, it is really, really a proud moment for me to having to get the opportunity. I did not know that you are here, but it's really a proud moment for me to deliver a talk in your presence. I would like to thank Professor Mudali. As he said, our association goes back to when he was the chief of the Heavy Water Board. We do a lot of things together. Many, many thanks. And I'm very grateful to you for considering me worthy of delivering this talk. To all other colleagues at HPNI, Professor Tyagi, Professor Selvan, and all other colleagues, thank you very much for sparing your time on a Monday afternoon. And there is rain and thunder. It is unusual for this time of the year, but we'll see how it goes. That's a welcome for me. Thunders for me. So let's hope that India thunders and India achieves self-sustainability in critical areas of platform technologies in the years to come. So my talk today is Innovation at Research at Tata Memorial Center, Practical Solutions for Affordable Cancer Care in India. But right off the bat, let me say that we are not an institute of technology. We are a very large healthcare institution dealing with cancer care. We also do some research related to basic and translational thoughts in cancer, but we are not an institute of technology. So therefore, our solutions, we do try to provide practical solutions about how cancer care should be delivered in India and countries like India. But we partner with colleagues from the Department of Atomic Energy and other institutions to be able to try to develop technologies. So this is just a cartoon that shows the whole world's population in the last 250 years. And if you see here, the population has grown rapidly starting at the beginning of about the last century. And it has grown exponentially. And if you see it on the screen, a large proportion of that increase in population is actually in the so-called developing countries and very little in the developed countries. Now, my idea is not into details of population dynamics over the years. What I want to point out is that the number of individuals who are older, which means people who are 65 years or older, have also rapidly grown in the past few decades, and the whole world's population is going to age. Whether we like it or not, that's what is called a demographic transition. In India, India's population will peak in the year approximately 2048 or 49 at a level of about 1.65 billion. And then at the end of this century, it will decline back to about 950 million. But more importantly, what will happen is that the proportion of individuals who are young will progressively decline and the older individuals will increase. Now, what that does is that there are many diseases, cancer, cardiovascular disease, many other diseases, which are primarily diseases of aging. So by the sheer fact of the population aging, we will have increasing number of individuals with those diseases. So I'm often asked the question, doctor, why do you think cancer is increasing? The most important fact why cancer is increasing is because we are living to an age to be able to get cancer. So I don't know how many of you know, but at the time of our independence in 2047, the average age at birth, not average age, the average lifespan at birth in India was actually 43 or 44 years. Today, it is 69 years. So, if somebody did not live to an age of 60, 65 or 70 or 75, how would they get on an average? How would they get diseases like cancer and cardiovascular disease? So by the very fact that population is increasing, of course, it will plateau, but the demographic transition is a single most important reason why we must be prepared to deal with a huge burden of non-communicable diseases, including cancer. So this is a map of the world by the incidence of cancer. And by incidence, I mean the total number of new cases of cancer divided by the denominator per 100,000 population. And you see the lighter color there is actually the less developed parts of the world, including India, which means that the incidence of cancer per unit population, per 100,000 population is lower than, for example, in places like North America and certain other developed countries. So numerator by denominator, our incidence of cancer is lower. And this is also true of females. And we are good in this respect, at least until now. But as we develop, as we adopt lifestyles that are more closely aligned to what we see in the developed parts of the world, it has been seen historically that the incidence of cancer continues to increase and it eventually matches that of the more developed parts of the world. So the challenge before India today is not to first attain that level of incidence and then decide how to control it and how to prevent it. The idea is to research some aspects of our lifestyle that have historically protected us from diseases like cancer. What is it about our diet, about our environment, about the way we live, about the way we eat and the way we clothe ourselves, that our incidence of cancer is 110 per 100,000 and that in New York is 380 per 100,000. There must be something. So the idea is not first to go up to 400 and then say, okay, we'll do something about it. We'll try to control it. I'm just saying this because, this is the big picture in front of us. This picture is evolving. But if we do nothing about it, if we don't research what is it, what has been good about our own culture, about our own lifestyle, we will inevitably attain all the negative aspects of Western lifestyle, and then we will have to do something about it. So this is the number of cancers, annual estimated number of cancers in India every year. Currently, it is about 1.35 million, about 13.5 lakhs. In 2040, it is expected to increase to about 21 lakhs. In terms of deaths, there are currently 850,000 deaths due to cancer every year in India. It will increase to about 14 lakhs in the year 2040. Now, if you divide 850 by 1350, 850,000 by 1.3 million, you arrive at a figure of about 65%. This is called the case fatality rate. So what happens is that in India, approximately 65% of the individuals who ever get cancer are destined to die of their disease. So we are lower in terms of incidence, but if you do get a cancer, there is about a 2/3 chance of dying of that disease. Now let me show you, this is Europe. So you can't see the numbers there. They are sort of not very well seen at this resolution, but this is 300 and approximately 350. Their incidence is 350 per 100,000. That many cancers occur. But if you see the red arrow there, that is about 120 per 100,000. That's a mortality. So on an average, about 1/3 of them die of the cancer once they get it, although their incidence is higher. If you look at Asia here, and India is also here, right there. And if you see, our incidence is about 120, but once you get it, there is about a 60% chance of dying from it. And of course, again, most of us will think about why this is the case. The most important reason why this is the case is because cancers happen at a more advanced stage. The infrastructure available to be able to treat cancer is deficient. And so therefore we must do something about it. At least we must think about it on the National Technology Day as to what can be done to. So we are good that our incidence is lower, but we are not good that a higher proportion of individuals die of their disease if they get it. So this is rural India. This is again the incidence. The incidence of cancer in rural India is even lower. I told you in urban India, it is about 110 per 100,000. In Europe, it is 350 per 100,000. In rural India, it is about 60 per 100,000. And this is not under ascertainment of cases that, cases are missed, nobody diagnoses, etc. and so on. This is from a very well conducted, very well run rural cancer registry where every single case is captured. So there is something about our traditional lifestyle that protects us from having cancer. The idea is not to throw away everything good about ourselves and then lament later on that, we have arrived where we have. So I told you that the incidence of cancer in rural India is even lower. Now, this is called the Million Death Study, and this was published by my colleague. The first author there, again, you can't see it, is Rajesh Dikshit, who's the director of Center for Cancer Epidemiology located within ACTREC. Now, this is the mortality due to cancer divided by rural versus urban residents and least literate versus most literate. Now you see, I told you that the incidence of cancer is lower in rural India. But if you look at the mortality, this is mortality, deaths per 100,000. It is the same in rural versus urban India, 95 versus 102, 96 versus 91. And if you look at it by the most literate versus the least literate, it is double in least literate compared to the most literate quartile of our population. So this suggests again the same thing. The chance of getting a cancer if one has been an inhabitant of rural India is lower, but once you get it, the chance of dying from it is higher. And it doesn't take a nuclear physicist, since I'm in a room full of people with nuclear physicists, to figure out why that might actually be the case. So currently, about a few years ago, so these estimates are updated once every few years. The most common cancers among men in India are those of the oral cavity, head and neck region, and lung. And the most common cancer among women in India is now breast cancer. It used to be cervix cancer, but now it is breast cancer. And the second most common cancer is cervix cancer. So again, a change of lifestyle, urbanization, changing reproductive patterns, breast cancer goes up, cervix cancer goes down. Now, there has been a sharp decline in cervix cancer. And that sharp decline in cervix cancer has been seen in every single cancer registry of India, urban, semi-urban, and rural. And this has been seen for the past 40 years. The incidence of cervix cancer in Mumbai in 1973, not 1973, 1993, was about 23 per 100,000. Today it is 8 per 100,000. There has been no vaccination, no screening in Mumbai in the past, no population-based vaccination or screening in the past 30 years. Why has that 23 become 8? Correspondingly, breast cancer is now 36 per 100,000 in Mumbai. It used to be 18 or 19 about 30 years ago. Something has doubled, something has declined by more than 2/3. We must research these trends, and these are very well established trends, to be able to figure out what is good, what is bad, and what should we do to sort of strengthen the positive trends, but do something about increasing incidence of certain other cancers. So let me change tack a little bit. This is the new building of the Tata Memorial Center. Our motto is to provide service, research, and education, and very importantly, to provide comprehensive care to one and all through excellence in service, education, and research. Very importantly, what is left unsaid here, regardless of their ability to pay for it. And of course, we are able to do it because we are very fortunate to be under the umbrella of the Department of Atomic Energy, the Government of India. So we were established in 1941 as Tata Memorial Hospital by the House of Tatas. In 1952, the Cancer Research Institute, which is now called ACTREC, was established under the Union Health Ministry. In 1962, TMH came under the Department of Atomic Energy, and in 1966, CRI also came under the Department of Atomic Energy, and both were amalgamated to form Tata Memorial Center in 1966. In 2002, Cancer Research Institute, which is the basic research wing of Tata Memorial, moved to the current location in Navi Mumbai in Actrec. And you can see that as of today, TMH has 650 beds and Actrec has about 500 beds. So we are we are the largest cancer institution in India. In 2014, we started functioning in another hospital, the Homi Baba Cancer Hospital in Vishakhapatnam. In 2015, we established a Center for Cancer Epidemiology in Actrec, and we opened another hospital, cancer hospital in Sangrur in Punjab. In 2017, we took over an old cancer institution in Guwahati called the B. Barua Cancer Institute. In 2018 and 19, we established the two cancer hospitals in Varanasi. In 2020, we started a new cancer hospital in Muzaffarpur in Bihar. In 2021, we established a new cancer hospital in Chandigarh, the Homi Baba Cancer Hospital. And what are ongoing and what will be completed in the next couple of years is one integrated center for treatment, research and education in Khopoli, which is about 40 kilometers from Actrec. And that is a unique institution where we will research indigenous systems of medicine alongside allopathic system of medicine to provide evidence for integrated cancer care. So there is a big piece of land given by the forest department to cultivate the indigenous medicinal plants. We are creating a hospital. There'll be extraction. We have now established collaboration with a number of Indian institutions which have some expertise in indigenous systems of medicine, and we will provide the evidence whether certain treatments work or don't work in a systematic and modern scientific manner in that place in Khopoli. And there is the last cancer hospital that is currently under construction is the Homi Baba Cancer Hospital in Bhubaneswar within the Nicer campus. So this is who we are currently. It's a snapshot you can see. If you count all of them and counting the two hospitals in Varanasi as two, we have 11 hospitals in 7 states of India, either functional or about to be commissioned, the last two that I mentioned. Of the pictures of all our hospitals, and of course, let me say it again, we are very grateful to the Department of Atomic Energy for enabling our vision. The problem is that we have become the victims of our success, and now there is a heavy demand to open up a Tata Memorial Center in every state and every city, which of course is unsustainable and cannot happen. And we are there as proofs of concept. We can show that Tata Memorial Center in Muzaffarpur in Bihar can work. Others have to emulate it with their own resources. We are there to provide technical help. But of course, we cannot be everywhere because that is not the mandate of Tata Memorial Center, and that is also not, I believe, the mandate of the Department of Atomic Energy. So if you look at that last figure there at the right bottom of your screen, it says 1,12,811. These are the new cancer cases who were registered in all our hospitals combined in 2021. And I told you that the number of new cases every year in India is 13 lakhs. So 1/10 of India's cancer burden is taken care of under the Department of Atomic Energy Tata Memorial Center hospitals in one of these hospitals. That 1,12,000 currently for the most recent year, I've not updated this slide, is 1,28,000. So within all our hospitals combined, we register 1,28,000 new cancer cases every year. The slides are not advancing. Yes, now it is done. Yeah. So in addition to establishing our own hospitals, we provide technical assistance, and you can see the number of state governments with whom we have a memorandum of understanding to provide technical help to them to establish their own cancer centers, right from primary prevention up to treatment. There have been two very important parliamentary standing committees, one of on science and technology, which is the controlling department of the Department of Atomic Energy, the other one on health and family welfare. And all of them have said that the model that Tata Memorial Center has provided of the hub and spoke model of delivery of cancer care should be taken forward by the government of India. And that is how cancer care will need to be delivered if we have to provide compassionate, good cancer care to all our fellow citizens who need it in the next 15, 20 or 25 years. So let me again change tack.
Comment about cancer specialists, like availability of people who are specialists in cancer treatment, please.
Yes, sir. So actually I have a slide on that, but let me,
Sorry.
there is one slide. I'm just coming to that. Maybe I should go to that slide immediately and then come back to this one. So this is the number of radiotherapy machines per million people. And you can see that in India, we are very, very deficient. Of course, in many other developing countries with respect to the number of radiotherapy machines per million population. And you can see these parts of the world have, maybe they have overdone it, but nevertheless, nobody, I mean, the number of radiation facilities, radiation therapy facilities are more than adequate to treat. So currently, even if we take the WHO norm of one radiotherapy equipment per million population, we need 1400. As per the AERB data, we have about close to 700. Of those 700, more than half are obsolete and they are not even functional. So you can see the number of functioning radiotherapy equipment and human resources that are available in India. So sir, this is to answer your question. If you look at the number of qualified oncologists to the population in millions, India is there. And I mean, you can't even see that bar. And if you see some of the other countries, they are, I mean, maybe, you know, some of them have overdone it, but at least, you know, we should be much better off than what we are today. And the problem is not just the numbers. The problem is their geographic distribution. So most of these individuals are concentrated, like I'm also in Bombay. I can't point fingers at anybody else. So I studied in Delhi and now I'm in Bombay. So most of the people are in the urban locations, large metro cities and others for justified reasons. But nevertheless, the fact of the matter is that it is very difficult to find qualified people to take care of our population in a well-distributed manner. So I was, you know, just going to say that what I told you, what I mentioned earlier, that cancers present in a more advanced stage. You see that SEER is the US data. That is the US registry data. And you can see that local cancer is about 60% there. And regional cancer is 33% and metastatic cancer is about 5% there. And these are data from several population-based registries in India. You can see that local is much less, regional is higher, and metastatic is also higher. So essentially, just by this very fact, the ability to cure cancer will reduce by a substantial proportion, just by this very fact, even if you have the same treatment, the same oncologist, the same infrastructure. So of course, you know, the Indian Council of Medical Research and others are engaged, and this is just one example of, you know, this tumor couldn't have grown to this size in 3 days. This person must be sitting on this tumor. And why did he sit on this tumor? Not because he's at fault. The problem is that he doesn't have the resources to go, you know, where it can be diagnosed. And I mean, one should not blame the person. The problem is with our healthcare system, we don't have a facility in the vicinity to take care of our population. So I've already talked about this radiotherapy. Now the good thing about India is that we have a robust indigenous pharmaceutical industry. You look at the cost of medicines. This is the same medicine, tamoxifen, Majestrol, CMF, the same medicine in India and the same medicine in the US. India is at least 1/5 to 1/10 cheaper than what it is in the US and in many other countries. So this is the good thing, that at least for common medications, not the very fancy medications. So since India became a signatory to the World Trade Organization and all the rules that are under that, ability of our pharmaceutical companies to replicate the new drugs has, I mean, they can do it only after the intellectual properties expires. But nevertheless, for the common medications that are used to the extent of 90% to treat cancers, we have a, I mean, they are the same in dollars and we are even lesser in rupees than what they are in dollars. So this is our strength, the indigenous pharmaceutical industry, and that is largely in the non-government sector. So we must congratulate the enterprise and the and the and the ability of our pharmaceutical companies to innovate and to produce. So which is why India is also sometimes called the pharmacy to the whole world. We did that not only for cancer medicines, but also for HIV. When the HIV medications were so expensive, we supplied to the whole world. And what is not often acknowledged is that the HIV epidemic in Africa, sub-Saharan Africa, was actually controlled because of medicines from India. And Cipla was one company that hugely contributed to that. So, there are some strengths that we have and there are some weaknesses that we have. So this is the number of new cancer cases who were registered in one calendar year. This is 2018 in Tata Memorial. You can't read the numbers, but let me bring you to the next slide. And it's not again advancing. Yes. So if you see, this is a heat map of the patients who were registered in TMC Mumbai. Now, for understandable reasons, so a fair concentration is from individuals from within Maharashtra. But look at the number of individuals from north, northeast, and eastern part of India who literally travel thousands of kilometers to receive their treatment in Mumbai. Now, this, of course, cannot happen if the resources are available at least to a fair degree everywhere. And this is so these patients were geotagged when they came to Tata Memorial, and then we figured out where they come from. But of course, one other thing that you must notice here in this figure is the fact that South India has very few individuals that are coming to Tata Memorial, which again attests to the fact that in some locations within India, good quality healthcare is available, and therefore the citizens do not need to travel far and wide to receive routine treatment for their treatment. So one thing that we have done in Tata Memorial Center is to create what are called disease management groups. So this is unique about Tata Memorial in India. This is unique about Tata Memorial. There are very few hospitals all over the world who have the capacity to be able to pull this off. So I treat only women with breast and gynec cancers. I don't treat lung cancer. I don't treat prostate cancer. I don't treat stomach cancer. My colleague who treats prostate cancer treats only prostate cancer. And this is for all specialties: medical oncology, surgery, radiation oncology, pathology, radiology. This, of course, is possible when you have enough number of individuals to take care. What this has enabled is high level of expertise within our institution. So Tata Memorial Center is the envy of the entire country, at least with respect to the human resource capacity and the expertise that we have within our hospital. And you can see these are 10 disease management groups. The patients don't run helter and skelter. All the individuals who treat bone cancers are located in one location in the hospital. The patients get seen by, of course, there is a large number of patients, so there is always a crowd, but everybody sits together, we discuss the cases together, and that is what leads to good outcomes in our patients. So let me give you a snapshot of the kind of research that we do at Tata Memorial Center, because that was also the theme for today. So we have enabled mechanisms to conduct ethical research at scale in our institution. This is called the TMC Research Administration Council. And many of you have heard about the Nuremberg trials and the infamous Tuskegee trial. So in the modern world, you cannot take human beings and start experimenting on them without so much as a buy or leave. There are complicated, stringent, strict rules of ethics which one has to follow. We are regularly monitored by the Drug Controller General of India, by the ICMR and everybody, to make sure that we conduct clinical trials in an ethical manner and consistent with the dignity and safety of human beings on whom we enroll in our clinical trials. So essentially, these ethics committees, clinical trial center, data monitoring committee are mechanisms, are proper mechanisms to ensure that we do things the right way and that we treat our patients and their families with the respect and dignity that they deserve. So let me talk about public health research, and I have to go back to the founder of ACTREC and CRI, Dr. Khanolkar, one of the most eminent scientists that India has ever produced. He and his colleagues figured out the association between tobacco and cancer simultaneously with Dolan Hill in UK. So Dolan Hill, as is usual, garnered all the glory for figuring out the association between tobacco and cancer. But see, this is 1955, British Medical Journal. This was simultaneously with Dolan Hill. And so, we are very proud that, our founder director of ACTREC and CRI were such distinguished individuals who simultaneously with everybody else, not everybody else, only two other people actually figured that out. They figured this out. And this is in Nature in 1945. So we were founded in 1941. This is 4 years after that, distribution of Rh factor in Indians. So coming back to the modern times, so this is a study, a randomized controlled trial that our public health epidemiologists led by Dr. Indranil Mitra conducted in the slums of Mumbai. So these are 150,000 women, 151,000 women divided half and half to receive no screening or screening for breast and cervix cancer, not by mammography, not by pap smear. Why not mammography and pap smear? Because where are the mammogram machines in India? Where are the radiologists to read mammogram machines? Then pap smear, where are the people to, read the cytology for pap smear? It is a complicated chain. So, once by the time a slide reaches a pathologist, it has already traversed several steps to actually reach there. Those steps don't exist in India. And you have to prove not just that, you can do it within the small confines of Parel, but you have to show and prove that it can be done in every nook and corner of India. So these women were randomized to receive clinical breast examination. Clinical breast examination means palpating a woman's breasts, not by doctors, not by nurses, but by women who are 10th standard pass, sometimes 9th or 10th standard pass, to be trained as healthcare workers. This was done in the community schools because, of course, 150,000, if you have to screen them every 2 years with whatever you are doing, you can't get them 150,000 to the hospital. So this is what was done. And of course, we have to acknowledge that the US National Institutes of Health actually funded this study. It was through an R01 grant by the US National Institutes of Health. And look at this. This is the cervix cancer mortality, deaths due to cervix cancer by visual inspection of the cervix with acetic acid. So when you apply the acetic acid on a woman's cervix, if it is diseased, there are aceto-white areas. So acetic acid is nothing but vinegar. Of course, you don't use the plain vinegar, but aceto-white areas are the abnormal areas. And this can be seen by the naked eye. It can be seen by women who are 9th or 10th standard pass. It doesn't need a complicated technology like a microscope and all kinds of liquid-based cytology to do it. 32% reduction in deaths due to cervix cancer. This received a standing ovation in the plenary session of the American Society of Clinical Oncology. So, that's a room, one single hall that has 10,000 individuals sitting there, 10,000. You can't imagine how big that hall is. The podium is so far away, there are multiple screens. The entire audience gave a standing ovation to the results of this study because, of course, this is saving lives. And, the theme of today is providing affordable solutions that can be implemented at scale. This is the breast cancer component of the same study. And again, a 33% reduction in breast cancer mortality only by palpating the breast by trained healthcare workers at regular intervals in women above the age of 50 years. Now, you see, what happens often in our usual practice is that in all spheres of our activity, scientific activity, I am a very eminent person. Sudeep Gupta is the director of Tata Memorial Center. He has said that this is my opinion, therefore it should be done. That is now not how it should be. We should provide evidence empirical evidence backed by, proper logical line of reasoning why something should be done. So breast cancer and cervix cancer screening by clinical breast examination and VIA by trained female healthcare workers is now implemented in 21 states of India at the primary and secondary healthcare levels. This is not done by doctors, it is done by ASHA workers. And just today morning in Tata Memorial, we actually were training healthcare workers from the Navi Mumbai Municipal Corporation area. Their commissioner has said that you train, retrain, because there are new workers who keep coming in. So this is what we are doing. This is what Tata Memorial Center has done in terms of providing a practical and feasible solution for India. So if somebody was to say that I will wait until every district, every sub-district, every small taluka has a mammogram machine and a qualified radiologist, then I think we would wait until another 30 years to be able to do it. But we cannot do that. We have to find our own solutions to our own problems. But if the result was not this, if the result showed that it doesn't help, then yes, we have to accept as scientists that the result doesn't help. So therefore, we have to look for something else. So this I've already said. So one more. So this is relatively higher technology. This is not yet a solution. This is just a scientific finding. And this is, by the way, published in Lancet, one of the world's top medical journals. So our colleagues from the Center for Cancer Epidemiology, so in North India and Northeast India, the incidence of gallbladder cancer is very high. And in the world, there are just 2 or 3 hotspots all over the world where gallbladder cancer is high. And it's a highly fatal cancer. Once somebody gets gallbladder cancer, then, it's like a very high mortality. It's very hard to treat it. There are many theories why it happens, gallstones, this, that. Our former director, Dr. Badwe, feels that maybe it is because of some infection with flukes. Somebody else says that this happens, by the way, in the Indo-Gangetic belt. In Mumbai, in South India, it is almost non-existent. In Chile, in South America, it happens. But, very few other places in the world. So our Center for Cancer Epidemiology has done genome-wide association studies. So this is, some of you may know, I don't know how many of you are from the biosciences group, but you can look at all the single nucleotide polymorphisms of the human genome on a genome-wide scale. And then they found out that this particular 2 SNPs here, ABCB1 and ABCB4, they are related to biliary transport. So in the gallbladder, the proteins that transfer the biliary salts in and out of the mucosa, they are strongly associated. I will not say cause. So there is most of you are, you have better capability in mathematical sciences than I do, but there is a difference between association and causation. It is strongly associated with gallbladder cancer. It may not be the cause, it may be a surrogate for something else. But nevertheless, this is a hugely useful finding now, because you can conduct targeted screening of the population. And most recently, with the blessings of the Department of Atomic Energy, there is now a screening program that is going on in about 5 lakh women in India, which will use their blood samples are being taken to figure out whether they have this genetic predisposition or not. And this is the very first finding in the world. We have not copied this. This is not something that was done elsewhere and then, just sort of rediscovered in India and in Tata. This is the very first finding. Subsequently, our findings have been replicated by scientists in the US working with the Chilean population. But the very first finding, and this has now been replicated by others. So this is not a fluke. It is a real finding. So let me give you a few other examples. So head and neck cancer is rampant in India, particularly oral cancer, for reasons that everybody knows: gutka, pan, tambaku, bidi, cigarette, all kinds of tobacco. And oral cancer is particularly high because, unlike the West, where smoking is more prevalent, we tend to keep the tobacco within the cheek and then sort of keep on chewing it. Now, the problem with oral cancer is that it goes to the neck lymph nodes as the first site of spread. Now, for a long time, there was no answer to the question that when somebody has developed an oral cancer, should you perform surgery to remove the neck or not? Neck is clinically negative. Clinically negative means I'm palpating the neck, there are no lymph nodes, but the person has a tumor in the mouth. Should you operate only on the mouth, or should you operate on the mouth and systematically Now, the reason why it is a big deal is that this is a complicated surgery. It has a potential to cause a whole lot of complications because of removal of the entire lymph node chain in the neck. So our colleague, Dr. Anil De Cruz, the previous director of Tata Memorial Hospital, led this randomized trial in about 600 patients. Half of them received neck dissection, the other half not. And you see, this is a single institution paper in the New England Journal of Medicine. Single institution paper. If you look up New England Journal of Medicine, people would give their left arm to publish in the New England Journal of Medicine. And then usually even in the US, most of the people who are able to do this are, several consortia and, from many other centers, usually funded by pharmaceutical companies. This was a second plenary presentation at ASCO. This was in 2017 and simultaneously published. And the reason why it garnered a whole lot of attention is you see overall survival here. It saves lives to perform the neck lymph node dissection. Until then, half the people were doing it, the other half were not doing it. Nobody knew how much to do from level 1, level 2, level 5, how much to do. So systematically it was, and I'm showing you these results in just one slide, 2 slides. It took 13 years to come to that result. Why? Because in cancer, the results are not evident on the next day. When you conduct a trial on a human individual, the cancer will come back or will not come back in the next 5 years, 7 years, 10 years. So first of all, to accrue those 600 patients takes about 7, 8 years. Then for all of them to achieve a follow-up of about 4, 5 years takes another 4, 5 years. There is unfortunately no reliable way of short circuiting that 12 years into 2 years that, today I do the treatment, tomorrow I find out in cancer. So it is possible in, let us say, Ebola. Ebola is something which will kill the individual in the next 28 days or the person will then survive, or next 56 days. But you don't have to wait in a disease like Ebola for 5 years to figure out whether it will come back or not. COVID, the result is usually apparent, at least the main result, whether it will kill the person or not in the next 2 months or 1 month, like that. In cancer, unfortunately, you have to wait years and years. You have to follow up each patient. So which is why, this is months from randomization. And this whole technique, statistical technique, is called a Kaplan-Meier curve. And the comparison between them, the statistical comparison, is by several complicated tests, including running regression analysis of the proportional hazards method. But you see huge improvement in both cure as well as in survival. And these are lives saved. So after this, performing neck dissection on patients with oral cancer has become the default standard, not just in India, throughout the world. So this is a result, again, we have not replicated from anywhere. The very first time that this has been proven. And again, you will say, it's not such a big deal, but, this is not technology, but, we are a cancer hospital. And therefore, we have to prove surgically, radiation-wise, treatment-wise, what will work and what will not work. So this is a low-cost oral drugs, and it was my colleagues from the head and neck cancer department proved that using low-cost oral metronomic chemotherapy. So oral metronomic is giving small doses of chemotherapy every day rather than giving a big, huge intravenous dose every 3 or 4 weeks. And now we have proven it by preclinical studies in animal models and also in cell lines, that giving continuous low-dose chemotherapy has many other effects apart from the main cytotoxic effect of chemotherapy. It actually inhibits angiogenesis. It stimulates the body's own immune system to attack the tumor. And so here you can say that this upper curve here is the oral chemotherapy. This is the intravenous chemotherapy. And you can see that the treatment that costs 1/10 of the intravenous dose actually has higher cure rates. So, and I have to also tell you that this is not something that the pharmaceutical companies will do. If somebody is selling a medication worth 15,000 every 3 weeks, why should they do a study to prove that, something that costs only 500 rupees is either as good or even better? So a lot of the results in medicine are not only the play of science, but they are also the play of commerce. And because the large pharmaceutical companies hold the reins of power, shall I say, it is they who decide the research agenda. It is for academic institutions like Tata Memorial to actually, and others like AIMS, like RDR, like GCRI, to actually counter that by doing research that is relevant to the patients. So cervix cancer. So now whether we should perform in cervix cancer surgery or radiotherapy. So this is actually, now I am the first author here, and I actually did this. This was again a plenary presentation at the European Society of Medical Oncology conference in 2017 in Madrid. Again a huge hall with almost 9,000 people sitting there, and you get awed when you speak to that audience. But you know, these plenary presentations are chosen from among thousands to be just 4 or 5. So here, you know, the question was whether you should perform surgery or radiotherapy for cervix cancer. And again, this question had not been answered. This has been published in the Journal of Clinical Oncology, and we showed that giving radiotherapy with small dose of chemotherapy improves in better cure rates than surgery. And again, you know, this has changed the practice, not just in India. Europeans were doing surgery, South Americans were doing surgery, and people in East Asia and Taiwan, Japan, everywhere they were doing surgery. The North Americans were anyways doing radiotherapy, so they were fine with what they were doing, but there was no proof as to which one is better. Now, you know, this actually, now the criticism of this study, because I'm the principal investigator, is that radiotherapy machines don't exist. I showed you. Everybody says that, you know, you have proven that radiotherapy is better, but where are the radiotherapy equipment? But the answer to that question is not to shut your eyes and say, okay, you know, since radiotherapy machines don't exist, therefore, you know, we will continue to give an inferior treatment. The answer to that question is to install radiotherapy machines, to provide the expertise where it is required, because radiotherapy is an extremely important form of treatment for cancer. And it was the original reason, along with the radionuclides and radioisotopes, why Tata Memorial Center was under the Department of Atomic Energy and not under the Department of Health. So, you know, this is a kind of a result that is a call to action for governments all over the world to say that we must provide appropriate radiation resources. And you see, it's not just installing a linear accelerator. It is, of course, the medical physics that goes along with it, the technologists who go along with it, the planning, the everything else that goes along with, you know, installing a radiotherapy equipment. More recently, again, my colleague Supriya Chopra and I, we were the principal investigators. We showed that a more sophisticated form of radiotherapy called intensity modulated radiotherapy actually results in lesser side effects to the bowel and to the bladder compared to the plain simple, you know, 3D conformal radiotherapy. Again, somebody will say that, you know, you are saying this, but there are a lack of even simple radiotherapy machines. You have proven that the more sophisticated, fancy radiotherapy is even better than the other one. But you see, as scientists, it is and as people who generate evidence, you know, we cannot prejudge what the outcome would be. We have to, if we have to be truthful to our science and to our results, we have to state the results as they are. And therefore, we must provide this capacity in many parts of India and other parts of the world to be able to deliver the treatment that our patients deserve. So this is a study on prostate cancer by my colleague Vedang Murthy. Hugely influential results. So again, you know, now prostate cancer is a cancer of affluence. It is also a cancer of over-testing. So, you know, if you perform a PSA test in the entire male population of Mumbai above the age of 70 years, about 40% of them would have prostate cancer. There are studies that are conducted in individuals above the age of 70 years who died of a motor vehicle accident unrelated to prostate. Their prostates were, you know, then on the autopsy, there were studies. Almost 50% of them have actually cancer in the prostate gland. But that is a cancer that is what is called overdiagnosed. So every ailment that you can discover with your technology doesn't actually necessarily need to be discovered, first of all, and then to be treated. Some of those prostate cancers are clinically relevant and they do need to be treated. The challenge, the current technological challenge, is to figure out which one is clinically relevant and which one is not, which is what is, you know, the current focus of research. But having discovered a cancer in the prostate, now the question is whether you should just radiate the prostate or you should radiate the whole pelvis. And why that is important? Because like oral cancer, prostate cancer also goes to the pelvic lymph nodes. Again, no answer to that question, no good answer to that question until Vedang Murthy proved in this randomized control trial, again published in JCO, and he presented this at the plenary session of ASTRO, the Society of Radiation Oncology. And you see huge increase in cure rates with radiating the whole pelvis compared to doing it only for the prostate. Now, this is a practical solution. This is a practical result, which in our parlance we say is applicable on the Monday morning. Most of the medical conferences happen on Saturday and Sunday. So what can be applied on Monday morning is of the highest importance. And this is something that can be applied on the Monday morning in the patient when you see the. So, when this was presented and then published by Vedang Murthy, this has changed practice in all parts of the world. Again, this is something that we have not copied from somebody else. Somebody sitting in Milan did it first, the other person sitting in Copenhagen did it second, and we only copied it. This is for the very first time that this result is there. So let me just say, so this is triple negative breast cancer. Some of you know that among all the varieties of breast cancer, this is the most fatal and the most aggressive variety. And this happens to the extent of about 30% in India. In the Western population, it is only about 10 to 15%. So so I had again the privilege of presentation at the San Antonio Breast Cancer Symposium. So you will say, I'm talking about ASCO, ESMO, San Antonio breast cancer. We have to yet come out of the fact that the best pieces of research from India get presented at international conferences, not in Indian conferences. Because, these are very, very prestigious conferences. There are tens of thousands of abstracts, and the ones chosen for either plenary or for oral presentations are a tiny, tiny, tiny proportion. So we tend to publish our best pieces of research in international journals. So JCO, which was Vedang Murthy and the other cervix cancer, they have an impact factor of 55. NEJM has an impact factor. It's not just impact factor, it's also the fact that, when you publish in such journals, the chance of people all over the world following and listening to what you have to say is much higher. But in 20 years from now, 25 years from now, India should have the best conferences and also the best journals for publication. It is also, among the power hierarchy, that is also something to think about. And some of us have been thinking about how to at least change the situation in the medical field. So I had the privilege of presenting this on behalf of all my breast cancer colleagues. So some of you know that there is a drug called platinum. All of you have heard of the metal called platinum, but there is a drug called platinum, and there was no good proof of whether it should or should not be used in patients with triple negative breast cancer, because this happens at a young age, and whether you should give this drug or not give this drug, it is a very inexpensive drug despite platinum being so expensive. So it is of practical relevance. So let me not, show you the details of all of this, but let me show you the results. Again, we accrued 720 patients over a 10-year period. And then I presented it in December 2022 at the San Antonio Breast Cancer Symposium with a median follow-up of about 68 months. And the response rate is much higher with platinum. The benefit is confined to women under the age of 50 years. There is no benefit in women above the age of 50 years. But in cancer, response is not the gold standard endpoint. It is survival. How many people live disease-free in the long run? So you see, this is that long-term disease-free survival. It is better by about 6.5% with the addition of platinum to usual chemotherapy. The benefit is solely confined to young patients and not in older patients. In terms of deaths, there is a 8% reduction, 7.6% reduction in the rate of death with the use of this drug. And then the benefit solely confined to younger women, and in older women, no benefit. And so again, the results of this study have established platinum as a drug in young patients with breast cancer throughout the world. So, we also did a translational study. We did something with the tumor samples of these women with triple negative breast cancer. So you see, some of you have read of Darwin. And although Darwin is solely credited with the theory of evolution, there was also a chap called Alfred Russel Wallace, who actually did it simultaneously, he's less credited. So human tumors also evolve in a Darwinian fashion. So, there are adverse environmental circumstances for the tumor, chemotherapy, hypoxia, other things, crowding, stiffness, this, that, and then the tumor has to evolve. So what we did, this is the work of my PhD student, very recently published in Cancer Research Communications. So what we did was to find out whether tumors evolve in a Darwinian fashion throughout their life history. So one woman diagnosed today, and I take the tumor samples and blood samples from her throughout her history right up to death. We have assembled that tumor, and this is an exceptionally difficult tumor collection to assemble. So let me not show you the minor results. Let me show you. So one thing was that aside from the tumor biopsy, the liquid biopsy, if you take out the blood sample and do a mutational analysis of the tumor, circulating tumor DNA, it completely captures the solid tumor biopsy. But believe me, it is like looking for a needle in a haystack. So you have to be exceptionally good at trying to sift out the ctDNA from the genomic DNA. But the main result is this. You see, this is the parent tumor in these 3 patients. This is the trunk of the evolution. This is the mother branch. And all these are daughter clones that are given off throughout the life history of this tumor. And what we did was we correlated this with what treatment the patient has received prior to each evolution. And that gave us good insight into what might be what clones. So these are called clones. This is called the mother clone, and these are all called the daughter clones. So we found out that the mother clone persists throughout the life history of a tumor. It periodically gives off branches of the tumor, and they are then, they are responsible for resistance to each subsequent line of treatment. This is among the last slides. So this is a study that was led by Dr. Badwe. Again, infiltrating a drug called lidocaine. It's a local anesthetic drug around the breast cancer tumor just prior to surgery. Just prior means minutes prior to surgery. And this was a study that was done in 600 patients, half of them. So this lidocaine injection costs 50 rupees, only 50 rupees. So you create a wall of this lidocaine around the central ball of tumor before you operate, before you sort of remove that tumor. And the hypothesis was that lidocaine blocks the voltage gated sodium channels. So at the time of surgery, if there was any tumor dissemination that was happening because of the blockade of voltage gated sodium channels, that egress of the tumor, the cell motility and other characteristics of the cells will be inhibited or not. So the only way to prove it is to give it to half the patients, don't do it in the other half, and then see them over time who gets cured. So again, you see, these are 1,600 patients, and this is the disease-free survival, the cure rate, and this is the overall survival. This is the local recurrences, this is the distant recurrences. A big benefit in cure rate, because breast cancer already has a high cure rate. So, you have to jump a higher bar to actually prove. So the cure rate is already about 85%. So this is increasing the cure rate and survival in a cancer where the outcome is already good, but still it needs improvement. And you see, this is something lidocaine 50 rupees, and this is a editorial in the same issue of JCO, where this trial was published. And this is Elizabeth Mittendorf from Dana-Farber Cancer Institute in Boston, and see what she has said. It seems reasonable to introduce this intervention as an easy, cost-effective treatment that may reduce the rates of recurrence and death in women with early-stage breast cancer. She goes on to write, which I have not unfortunately not included here, that this has a potential to save tens of thousands of lives all over the world. So this is not something that will cost you $500,000 every 4 weeks, or at least once in the patient's lifetime to be able to increase. So let me, just say that treatments may be effective, but they're useless if patients cannot afford them. Because there are many treatments which are very expensive, but only 2% of patients can. So this is trastuzumab, and we did a study in 2010, and we found out that this is a very effective drug, but only 8% of our patients are able to take it. Then in 2016, we again reevaluated, and only about 60% of our patients are able to take it. So then we actually were wondering whether this full 1 year of this treatment, which costs about 6 lakhs of rupees, is required, or you can get away by doing only 9 weeks to 12 weeks. So the other trick that these pharmaceutical companies play is to establish a longer duration of treatment as the default standard. Now, whoever has to prove that that much length of treatment is not required has to do what is called a non-inferiority study. So there are two kinds of studies. One is called a superiority, where the experimental arm is superior to the conventional arm. The other one is non-inferiority, that I am at least as good as them. So, we conducted a individual patient meta-analysis, and we have published this in JAMA, so Journal of the American Medical Association, again a top journal, and we showed that 9 to 12 weeks of this expensive drug is non-inferior to 1 year. So as a result of this analysis, now the not Niti Aayog, the Ayushman Bharat, the National Health Authority, has approved 9 to 12 weeks of trastuzumab as the default standard, and we have conducted a cost effectiveness analysis with colleagues from PGI Chandigarh, and we have seen that at the current level of India's GDP per capita and the cost of this drug, 12 weeks is actually cost effective in India. So, we have learned many lessons. The most important lesson that we have learned is that well-designed clinical trials or other correlative studies are likely to. So the chairman is calling me. Should I? Sorry. So, well-designed clinical trials are likely to answer important questions. And, we need a relevant question that is relevant to India. We don't need to do fancy, glamorous research that will appeal to somebody sitting in Boston or in Connecticut. We need to do studies that will be useful in Akola and in Delhi. And, all of those, and meticulous follow-up, and very important, funding and appetite for long gestation period. And we are very, very grateful to the Department of Atomic Energy. Almost all the clinical trials that I showed you, except for the first one, that screening trial, center. So whenever I make this presentation, people ask, but who waited for 10, 12 years for you to publish your results? Our funding cycle is only 3 years. We want the result in 3 years. I tell them that in 3 years in cancer, you cannot get a result. 100% you cannot get a result, at least a clinical result. So, the future, of course, I'm showing you, so artificial intelligence, etc. But I have to show you one more thing. So, this we have received a funding of about 12 crores of rupees from the Department of Biotechnology, and I am the coordinating principal investigator. We are creating an imaging biobank for cancer. So in 10 different cancers, we are collecting their MRI, mammogram, as well as their pathology slides, the images of pathology slides, and their longitudinal information. And this bank has already been created. Now, this is a gold mine for individuals who work with deep learning methods like convolutional neural networks and others to be able to figure out. So, for example, the idea, I'll tell you the futuristic idea. There are a number of biomarkers that can be tested only if you biopsy a tumor. Can I show an artificial intelligence algorithm only the picture of a CT scan of a tumor and ask that AI algorithm to tell me what is a biomarker even without doing the biopsy? Something like that. So, this is, first of all, you have to create a bank that will do it. We have created the bank. This is the very first bank in India. And of course, this will shortly be launched by the Department of Biotechnology with us, because we are the principal investigators. So we have collaborated with AIIMS Delhi, PGI Chandigarh, and a couple of and IIT Bombay for this. But so this is, so we are about to do, so this is already done. So this is artificial intelligence. Now there is this guy called Dobzhansky, and he said around the year 1970 that nothing in biology makes sense except in the light of evolution. And the reason why I'm sharing you with this with you is that, I have realized over time that nothing in nothing in medicine also makes sense, and in the medical sciences and research makes sense except as a continuity from the past. So, one must have a sense for history to be able to figure out which trajectory you are following. Want this advance? Yeah. Yeah. So, I often find my colleagues lamenting that whatever was easily discoverable has been discovered. Now, whatever remains is much harder to do. So, the relativity was relatively easier at that time. Heisenberg's uncertainty principle was easier. Now, they've done all the big things. Now, it's hard to do. But, I have realized for myself that, with every new generation, low-hanging fruits materialize out of somewhere. If one is perceptive enough, then one will find the low-hanging fruit somewhere or the other. That's my last slide. Thank you very much for your attention.
Thank you so much, Dr.
Maybe,
Gupta.
are there any questions or comments?
Yeah.
5 minutes, of course. 5 minutes. A lot of students are there.
Yes, of course. Yes, there is a question from there. Yes. So the question that she's asking is that, you did a meta-analysis of all the randomized controlled trials of non-inferiority of shorter duration trastuzumab versus the full 1 year. But then how would you present that result to the patient? That is what you're asking. And what would convince the patient to take only 12 weeks was that your question? Yes. So it was not there right from the beginning. You see, the other thing that I want to convey to you is think about, how much uncertainty and sacrifice the patients make. You see, whenever you conduct a clinical trial, the result of that is not preordained. Although we conduct clinical trials to prove that whatever we are doing is more useful, we can never be sure about it. So patients who there were 12,000 patients, by the way, in that meta-analysis. I did not show you the denominator. Half of them received duration, the other half received the full 1 year. When they were participating in that trial, they did not know that 12 weeks or 3 months will be as good as the 1 year. But by follow-up, we figured out that the rate of relapse and the rate of death was no different, not statistically significantly and meaningfully different between the two groups. So which is why we must also applaud the courage of the patients who participate in these clinical trials. And that is why it is important to conduct these clinical trials to the highest level of ethics and safety. So, there are some pharmacokinetic reasons. So, most of these antibodies, so this is a monoclonal antibody, they have a half-life of 3 weeks. And these pharmaceutical, despite what everybody thinks that there must be some great science involved in giving 60 milligrams twice a day for 3 months, actually it is largely empirical. So one has to figure out from preclinical studies, from mice model, from early, non-randomized studies, whether a lesser duration might also be useful. So actually in the set of those studies, there were some that gave it for 9 weeks, others that gave it for 6 months. And of course, the control arm in all of them was 1 year. So what was shown was that 9 weeks to 12 weeks was one group, 6 months was another group, and 1 year, both the shorter durations were as good as 1 year. But there is unfortunately no technological way of figuring this out except by randomizing patients and figuring out, patient by patient.
My question is, what are the critical questions that a clinician requires from a basic scientist so that can be useful for affordable cancer treatment?
So the first question that a clinician will ask, that I will ask you, if you're a basic scientist, I'm doing this test which costs me 20,000 rupees. Can you do a test that which will give the same accurate result, which will cost me only 2,000. The second question that I will ask you is that this is a test that I'm doing, which involves a high technology platform costing 25 crores of rupees. Can you please give me another test that will not require this level of sophistication so that it can be replicated throughout India? The third question that I will ask you is that, I'm treating these patients with pancreatic cancer. On an average, when I count them after 5 years, only about 10 to 12% of them survive and about 88 to 90% of them die. Can you please do something that will improve this 10% cure rate to at least 20% or 25% or 30%? The fourth question that I will ask you is that, I have to wait for 10 years to find out the results of a clinical trial. Can you find out a biomarker for me, which is a near perfect surrogate? There is nothing called perfection. That limit going to zero is also true for everything. Can you give me a surrogate biomarker, a simple blood test that will accurately predict the results of my clinical trial? So that I don't have to wait for 10 years. I can tell you by doing that blood test at the end of my experimentation, whether, this thing is as good or better than the other one. So there are actually scores of good questions that come to a clinician's mind. And this is something that a clinician will grapple with every day sitting in the clinic. But of course, unfortunately, most doctors have no sense of, not no sense, let me not say, but many of them, have very underdeveloped sense of quantitative reasoning, mathematical reasoning and technological reasoning. Because, most of the people who are afraid of mathematics, then they take biology and they become doctors. But, mathematics without mathematical reasoning, without quantitative reasoning, without that, it is impossible to progress in science. So unfortunately, doctors have to collaborate with scientists and especially with physical scientists to make real progress.
Now we are going to artificial intelligence.
Yeah. Ask question.
Very good.
My name is Ganesh. I'm from Bioscience Group in BRC. So my question is regarding PARP inhibitors. So you would know that PARP inhibitors are a very a standard mode for BRCA mutant patients in West as well as in the Europe. So why are we not adopting? That is the question actually. Why are we not adopting PARP inhibitors in the clinical setup in India? And is it because whether we do not have the target cohort or is it because of the cost effectiveness?
So the short answer to your question is that we have already adopted. Short answer. The long answer to your question is that about 8 months ago, many Indian companies, the intellectual property on the original PARP inhibitors expired. So what was available for 1,08,000 rupees a month now has become available for 18,000 rupees a month. So it is largely adopted. The second, slightly another nuance to your question is that these PARP inhibitors are not useful in every single patient. There are tumors that have what is called homologous recombination deficiency. So, all human cells, not just human, all cells, all living organisms which are comprised of DNA have a mechanism to repair the DNA because, unless one can repair the DNA efficiently, one will not live. No organism will survive. One of the Achilles heels of tumors is that they are somewhat less good at repairing their DNA compared to the normal cell. Now, if the deficiency in DNA repair crosses a threshold, then if you give a hit by something that will damage the DNA by a complementary mechanism, this is in biology, it is called synthetic lethality. So synthetic lethality is that a stool is standing on 3 legs and it is barely standing. If you knock out one more leg, then it will collapse. So this poly-ADP ribose polymerase inhibitors. This poly-ADP ribose polymerase is one of the mechanisms of DNA repair. And the inhibition of this is hugely useful in tumors that are deficient in DNA repair. So now it is implemented. The problem was that, the testing for the homologous recombination deficiency is also very sophisticated. Now, about 8 months ago in Tata Memorial Center, our molecular pathology department has standardized. Now it is rolled out and we are doing homologous recombination deficiency tests. So, that is, so the long answer to your question is that it is adopted, and now it is, of course, 18,000 rupees a month is also very expensive for India, but it is now accessible to a larger number of patients.
This is for maintenance therapy, I believe.
Yes, largely for maintenance.
Thank you so much.
Largely.
Sir, I have more than a question, a comment. A close friend of mine was diagnosed with triple negative breast cancer, and within 1 year, we got a news that she is no more. It was a big shock to us. So I read about this, and I also read that it is BRCA genes, which is found to be reason for triple negative cancer. And I also read those days was a very big international news that Angelina Jolie, a famous Hollywood star, was found to have this gene, and she opted for surgical removal. So is this the only way to face this kind of very rare genes?
I think, Professor Taggi, you asked a very important question, also a very sophisticated question. So BRCA is again a DNA repair mechanism. And there are two genes, BRCA1 and BRCA2, which are actually involved with DNA repair. There are a number of other genes as well, RAD51C, RAD51D, but BRCA1 and BRCA2. So what happens is that if these genes, so all genes, they don't act by themselves. Genes actually make proteins. So if these genes are mutated in the germline, which means they go from the father to the daughter, or from mother to the daughter, or from mother to the son, then from birth itself, one is deficient in those in a DNA repair mechanism, and the lifetime incidence of breast and or ovarian cancer is about 80%. So, people who have these, so now earlier, I'll tell you one more quirk. There's a company in the US called Myriad Life Sciences. And what they had done was, they were, of course, the Mary Claire King. She discovered these BRCA genes and the mutation in BRCA genes. But then as happens in the US, this test was licensed to Myriad Genetics. Until 2012, they had a patent not only on the gene, that nobody in the whole world could test that gene. Nobody could test by any technology. Then the US Supreme Court fortunately saw reason in 2012 when they said that genetic sequences and variations in genetic sequences are acts of God and they are not non-patentable. So after 2012, what has happened is that now, a lot of it is sophisticated test, but it has been standardized. Now in our own cohort, we just completed a study in ovarian cancer, unselected, not by family history, just person walking in through the door with ovarian cancer. Our own study, I'm the first author, I have not shown that study here in 11 centers of India. 21% of ovarian cancer patients have a mutation, pathogenic mutation in BRCA1 or BRCA2, and about 10 to 11% of breast cancer patients. So there are a number of ways. One thing is to, of course, take out the ovaries and the tubes. The other one is to remove both the breasts. But removing both the breasts of a person who's otherwise normal is a very disfiguring and a very, shall I say, a very cruel treatment. So what one does these days is to try to convince these women that although there is a time bomb ticking over your head, we will keep you under close follow-up. We will closely do your mammography, your MRI every few months. And if the cancer gets picked up, it will get picked up at an early stage, and we will provide you with the same cure rate as we would by just removing both the breasts. So by the way, this applies not just to BRCA1 and BRCA2. There are now about 100 genes whose mutations have been found to be associated with a variety of other syndromes of human cancer. So, this is where we are progressing. And now the tests for testing mutations in this whole panel of genes are now reasonably widely available and accessible, including at our own center. Okay.
I'm a PhD student from HBNI. I have a question that what all factors of related to population genetics might affect a clinical trial?
Very good question. So what she's asking is, what features of population level genetics can affect individual clinical trials? So later on, I will ask you why you asked this question, because this is a very good and a difficult question to answer. So one example that I will give you is that study that I showed you, where we did a genome-wide association study and we found that two SNPs These are single nucleotide polymorphisms. They are not mutations in two genes were associated with a disease. So the population level prevalence of that SNP, for example, will dictate whether you enrich a clinical trial population for that particular genetic mutation or not. I will tell you another example. There is a very commonly used chemotherapy drug called 5-fluorouracil. Some of you have heard of it. It's a DNA analog. Now, there is an enzyme called dihydropyrimidine dehydrogenase that breaks down the drug 5-FU. There are people who are deficient in that enzyme DPD and in whom even a whiff, even a small dose of that 5-FU will be fatal. Now, unless, when you're doing 5-FU, if you enrich if you segregate those patients who are genetically, inherently, hereditary basis deficient on DPD, one has a potential to kill some patients in a clinical trial and also in routine treatment. So population level genetics and the distribution of various alleles and polymorphisms as well as high penetrance mutations is extremely important for designing clinical trials, enriching clinical trial populations, and then having adequate power for the results.
There is one question in online.
How to reduce?
So the question is from S. Chinna Esaki, how to reduce the treatment cost in modern radiotherapy modalities? That's a good question. And when you don't know the answer to a question, the first response is it's a good question. So, I will tell you my core specialty is actually as a medical oncologist. So, that is why I showed you some of the clinical trials that we did. There are several ways of, also trying to reduce the cost of radiotherapy treatment. The problem is that radiotherapy machines are a kind of a monopoly or a duopoly, or a very few people, very few manufacturers all over the world actually make the equipment that is required for radiation. And unless we break that technological stranglehold that they have on these high technology equipment, we will not be able to reduce at least the capital cost. I will give you one example from cervix cancer, of which I am a specialist. So, there is something called brachytherapy. Brachytherapy means you give intracavitary or interstitial radiation within the body rather than as an external beam. One way of giving that in cervix cancer is by what is called MR guided, means magnetic resonance imaging delineation of the tumor, and then you guide the brachytherapy ovoids, etc., everything according to that. But my colleague Umesh Mahanshetty, he found out that if you do it ultrasound guided on a full bladder, you will achieve the same results of toxicity and efficacy as if you were to do it with an MR. The problem is many of these low-cost solutions also require high level of expertise and inter-observer reliability. So, I don't have a straightforward answer to your question. My first answer to your question is that India should make high quality radiotherapy machines so that we don't need to import them. The costs of radiotherapy will immediately come down by itself.
Thank you so much, Dr. Sujit Gupta, for a wonderful and informative lecture on the affordable cancer care in India. And I think on this National Technology Day, we are fortunate that we have with you listen something that is totally benefiting the technology, that is benefiting the mass of the country. And like the National Technology Day gave energy, the strategic security to the entire country. Today you are talking about cancer care that will also give benefit to the entire country in from north, south, east or west. Thanks a lot for joining us today and sharing your thought and the innovation and research that is being pursued at TMC on the cancer care that is affordable to our Indian citizens. Thank you so much.
I now request Professor Mudali, Vice Chancellor HBNI, to present our token of gratitude and appreciation to Dr. Gupta. Thank you, sir. As we move towards the end of the program, may I now request Professor P.C. Selvin, Registrar HBNI, to deliver the vote of thanks.
The advance of technology is based on making it fit in so that you don't really even notice it. So it's part of everyday life by Bill Gates. Very good evening to honorable person here and who joined through online also for the National Technology Day celebrations of HBNI today. The 2024 Technology Day theme is from schools to startups, igniting young minds to innovate. I submit our heartfelt gratitude and thanks to our Sudeep Gupta, Director DMC, for accepting our invitation and delivering the special lecture on innovation and research at TMC, practical solutions for affordable cancer care in India. The lecture is an eye-opener for many and highly informative and great source of knowledge sharing who are working in the discipline of life sciences and medical and health sciences. He has touched a lot areas starting from the history of TMC and data about lot, and he has given a problem why breast cancer has doubled compared to cervical cancer, a research problem for the students, and have a lot of informations about the achievements of Indian scientists, especially in the field of medical sciences, through TMC. And can say, just I conclude one of the imaging biomarker for cancer funded by DPT using this AI for cancer treatment and lot about that are really a source of inspiration. And we always feel that some of the presentations through Dr. Sudhir Gupta made in the conferences made standing evaluation. I think there is no doubt. He is an excellent teacher, having all this knowledge, and through his presentations, we understood that really all this lecture also today also needs a standing ovation. So I really make this as an excellent presentation that
I'm so.
thank you, sir. I thank Professor A.K. Tyagi, Dean HBNI, for proposing the formal welcome address for the program. I thank Professor Lee for his presidential address and introduction to Sudhir Gupta to the audience. I thank Dr. Chidambaram, former Chairman of Atomic Energy Commission, for joining us today to celebrate Technology Day at HBNI. So whenever there is a lecture program of national importance held in this, we could expect Dr. Chidambaram here. And today he has proved that he has joined us today. Thank you, sir, for joining us today. I thank Dr. Rachna Agarwal, the program coordinator, for all the necessary arrangements and meticulously planning the event with most care. Thank you, ma'am, for your master of ceremony also. I thank all our associate deans, assistant deans, and administrative officers of HBNI Central Office for joining the event. I thank all our directors, deans, academics, dean student affairs from the constituent institutions of our campus center for joining the program. I thank all our scientific officers and faculty members of HBNI from BRC and students of HBNI for your on-site participation in this important celebration of Technology 2024 at HBNI. Thanks to you all for all your active and patient listening, contributing to a great extent for the successful completion of the celebration National Technology Day 2024. Thank you so much. My special thanks to Professor Tyagi, Dean, for his special request to the Deans of BRC facilitating our students to take part in this event today. I thank our technocrafts, IT team members of HBNA, and Madam Kranjit and Smita for arranging the snacks. And the talk itself, Professor Sudeep Gupta, is talk about the sustainability. Before I conclude my vote of thanks, I'd like to quote our chairman, Atomic Energy Commission, Professor A.K. Moganty's words. Self-reliance is an integral part of DAE programs, and it has enabled not only the successful combat of technology denials, but also the development of spin-off technologies that complement the Atmanirbhar Bharat programs. And today, Dr. Sudhir Gupta explained beautifully and presented a thought-provoking and exemplary lecture on practical solutions for affordable cancer care in India. Thank you all. Jai Hind.
Thank you so much, sir. National Technology Day is a day to showcase our national pride, and so it would be incomplete without paying respect to the motherland. May I request all present here to rise for the national anthem, please? Thank you all. The ceremony concluded. We all move out for the snacks outside. Thank you. I said, all present here invited to join us for the refreshments outside.